Thank you very much, Wagner, for this kind introduction. Dear ladies and gentlemen, now you have to listen to Austrian English. I hope this is acceptable. You understand, Austrian English and German English are a little different, so I think it's like Spanish and Portuguese. We like more the melody, you know. So sometimes we swallow endings when it doesn't fit to the melody, so I hope I do not swallow too much, and I give you a clear message about guidelines. So after listening to the wonderful talk of Professor Busato, you wonder how can you apply this then to treatment modalities. And you see here from the picture, it's a bird's eye view from Europe, that sometimes we thought all the wonderful guidelines, they come from this island offshore Europe in UK, and sometimes we wonder if they also apply to us in Europe. So you might think, how do they apply to you here in South America? What about the American guidelines? It can be a very dry theme about different algorithms, but I do not want to lead you through the different algorithms. I just would like to show you the difference which need to be considered. Before I start, I have some disclosure and conflict of interest. Guidelines cover all different types of medication, so therefore I would like to declare this. Also in Vienna, you know, we are the famous psychoanalytic country. The patients nowadays, they're going to the psychoanalyst, they ask them, what about your CME points, continuous medical education? So sometimes they probably don't know that psychoanalysts, they don't like diagnosis, and they have mostly their own algorithm, which we would say it's not evidence-based, it's more eminence-based. So this is the difference where we have to deal with. When we go to the different categories like eminence-based versus evidence-based, of course, the evidence-based medicine could also mean that probably this is the only possibility to bridge the cultural different treatment habits and minimize the influence of marketing strategies through different companies, but not only companies, also opinion leaders. When you think like one school of psychotherapy, then the other school of psychotherapy, the clinical experience basis, it's always said, well, they focus on the real world. But on the other hand, it gives also the priority to medication which are familiar to treating physicians. On the other hand, it also utilizes the experience with the treatment in controlled studies. To continue, I would like to stress a little bit the guidelines from the World Federation of Societies of Biological Psychiatry, and you see some national guidelines over here, country-specific. I'm not quite sure in Brazil if you care very much about the Austrian guidelines. Who is brave enough and raise their hand? Austrian guidelines, not very popular in Brazil, I think, right? But on the other hand, who cares about the American Psychiatric Association guidelines? Probably a little bit more, right? At least one or two hands. So they're getting more. So all of them are national guidelines. And I have to tell you, in Austria we have more medication than our American colleagues, like clomipramine, for instance, anafranil, never got the license for antidepressants in the United States, or some other medication also, and therefore you do not have them on the American guidelines. The British guidelines for psychopharmacology, also country-specific guidelines, and there are also further guidelines like the NICE guidelines from United Kingdom, which I will discuss later. So I think it's quite important that we view not only national guidelines but also international guidelines, and the WFSBP, where also Brazil is a very active member, the only worldwide approach. So let's go a little bit more into the detail. What do the recently published guidelines include? What problems need to be discussed? So usually the national treatment guidelines, they focus on their facilities and the habits and leave many crucial points open, like what to do after the first step was successful, what should we do at the second step, because the evidence-based guidelines, they would need also different controlled studies for this, which we do not have. What about polypharmacy, meaning giving more medication than just one? Right now the situation, like in Austria, Germany and Switzerland, when the patients leave the hospital, they get in the mean 3.5 medication. I'm quite sure, Wagner, in your department probably it's better, but at least 2 they also get, right? And it's now we are living in a time of polypharmacy. So all over the world, the patients get more medications at the same time, and needless to say, we do not have data who speak for this. Then, on the other hand, the different facilities where the patients are need to be considered also. Here is one of the example of a World Federation guidelines, and you see it has a little bit German focus. The lead author of this is Professor Falkay, Professor Gattas, who had also a large experience in Germany over, I think, 18, 19 years, right? And then also colleagues like Jeffrey Lieberman. So you can freely download these guidelines by our homepage, and you find the different guidelines for schizophrenia, acute, long-term, bipolar disorder, personality disorder, depression, anxiety disorder. And keep in mind, they include all different types of medication which are available worldwide. Since not all doctors read these English-speaking guidelines, it's very important that we have also national guidelines, like the guidelines have been translated from Professor Gattas and his team to the Revista Psychiatrica Clinica, and I understand not only for schizophrenia but also for other also diseases. This is available. This is a wonderful publication from Brazil. In Austria we have a very small publication like for bipolar disorder, what we would say psychiatry light. But you have to understand Austria is a small country, 8 million people, like a suburb of Sao Paulo, so we don't need such large, big guidelines. But the topics are pretty much the same, concluded in there based on the available literature and also giving a reference to the world guidelines. So the short story is, I think the national guidelines should include this international approach. Just to show you, like the other one, like that would be for unipolar depressive disorder. And needless to say, these guidelines need to be updated on a regular basis. How do these guidelines emerge? How do the doctors come to this? There is a chair, 2 co-chair, a secretary, then the task force, where the World Federation tries to bring together a large number of opinion leaders, and should be a worldwide geographic distribution. Nowadays it's easy with the electronic exchange, with the emails, and of course a Medline search. And finally, then there are some categories of evidence, A, B, C, D, and finally recommendations. And when the colleagues, they read all the available literature, then there is huge discussion going on here and the categories of evidence. But I would like to address the problem that the categories of evidence, they are not always easy to detect, and the different types of grading not either. Because if you look here, for instance, at the older guidelines, which were revised recently, like in the World Federation, we had A, B, C, D, and then no level of evidence, and we said, well, at least 3 moderate, large, positive, randomized controlled trials should be available, double-blind trials. B, at least 2 moderately large randomized double-blind trials, and so on. Like the expert opinion, which is sometimes prevailing, is just level D. These are the world guidelines. So is evidence A equal to evidence E from another guideline? Like I mentioned to you, the British guidelines or the APA guidelines. Just look at this. When you look, for instance, for the NICE guidelines is very important in UK, and it's called the National Institute of Clinical Excellence. Some colleagues say it's not national, it's not clinical, and it's not excellent. But look, compared to the world guidelines, the highest evidence here comes from meta-analysis. I will address this a little later. What is meta-analysis? Some people think this is something very good, because not a lot of people understand meta-analysis. And suddenly they say at least one trial, this or the other. Remember, the world guidelines say 3 trials, right? Then they come down, 1 trial without randomization is already category 2. And you see, you bring in a lot of different treatment approaches if you open the categories to non-randomization. But I tell you, some health regulatory authorities, they like these guidelines quite much because they can bring in other treatments which are sometimes also not so good. Let's look at the British Association of Psychopharmacology guidelines. Interestingly, they also have meta-analysis as their highest evidence, 1B, evidence, at least 1 randomized controlled trial. You can see already the British Association of Psychopharmacology, they are close to the NICE guidelines. But these are very vague guidelines, and somebody thinks, well, British Association guidelines, APA guidelines, these are big countries and important countries, they must be good. But if you look at the APA guidelines, meta-analysis suddenly is category E. It goes down from A, B, C, D, E. With British guidelines, it was high up in the mountain. So why can't this be the case for the APA guidelines, randomized, double-blind clinical trial? It's quite good that they charge this. But A- is already not double-blind and only randomized. So not double-blind. Everybody who conducts studies realizes not double-blind, you can have no good results. So big differences between these different guidelines, NICE guidelines, British Association guidelines, APA guidelines. Of course, as a former president of the World Federation, we think our guidelines are much better indeed, and we can discuss this. I think they are more rigorous. So then we come to the grading, and the general problems for grading is there is no international consensus on the evidence, and most guidelines, they refer to meta-analysis as the highest grade of evidence. So I'm quite sure if you read the latest meta-analysis from Cipriani in The Lancet, it came out in January. It was kind of a meta-analysis where all the studies the available were put together in a direct and indirect way. So you did not have to have a comparison of substance A with substance B. If B was compared to C and C was compared to A, then you also could say, well, this has a connection also to B. Austria, let me give you a practical example. Soccer is not our most favorite sport, like in Brazil. But you probably remember Austria last year beat France in soccer. And you probably remember France beat Brazil in soccer. So Austria is better than Brazil, right? Do you agree? Probably not, right? But this is the type of meta-analysis done by Cipriani, this indirect comparison, putting all data together and don't really compare the individual studies. So take home the message, whenever you read meta-analysis, it's a very low evidence, and think about Austria is not better than Brazil in soccer. So this is the short story, right? Other guidelines result from individual studies with high methodological standard being more important. This has been also viewed in this paper from colleague Bandelot. This is, for instance, one of the meta-analyses which traveled like 2 years ago through all the press, Kirsch paper, when they said, well, the antidepressants don't really work. Placebo are better, so basically the antidepressants are very poisonous placebos. That was the general message. These colleagues are all psychotherapists. I don't want to speak against psychotherapy. They are cognitive behavioral psychotherapists, and they like to push cognitive psychotherapists. They come from England, never used a medication in their life. And what they did, they said, we are very formal, and we take all studies which have brought to the FDA, the American Health Regulatory Body, when the medication was registered. Okay, one could say a very standard procedure, all of the medication term. So for instance, they took fluoxetine. Fluoxetine was brought to the FDA, I think, in 1987 or 1988. And in between, there are at least another 70 to 80 studies being published. So they published these kinds of results in 2008 and did not report about 90% of the available studies. And they came out, well, that the antidepressants only work in very severe depressed patients and not in mild and moderate depressed patients. So a lot of methodological problems. The selection criteria of this meta-analysis is very important. Some statisticians say, well, you only get what you put in, and you put in garbage in, then you get garbage out. So this is basically the story of the meta-analysis, and I would like to alert you, do not look at this. This has been also addressed in our paper from Bandelot, then Zohar, Möller, and myself, that how to categorize the levels of evidence. And the way how we do it now in the revised world guidelines is that we have different categories of evidence. We call it full evidence, limited positive evidence. So the full evidence, we ask for 2 double-blind, parallel group, randomized controlled trials, and 1 more positive showing superiority or equivalent efficacy. So 2 studies are asked, and this is pretty much the same what is also asked from health regulatory bodies like the European Agency of Medical Products or the FDA. They also, before a medication is licensed, they ask for 2 double-blind randomized trials. We also addressed the question, well, if there are negative studies available, then the positive studies should outweigh the negative studies. So I think also very important approach. And this goes on then to like category D, E, F. So these uncontrolled studies, which are, for instance, as I showed you before, in the American guidelines, even A-, they get a C in our category. Well, the side effects usually are not addressed in all the different guidelines from the different countries, like weight gain, for instance, or I could have sexual dysfunction from the antidepressants. Usually, these side effects do not go into the guidelines, and therefore the clinicians say, well, I cannot use these guidelines because the patient doesn't take it. So, I think it's quite important that not only the evidence level from the efficacy, but also from the side effect level should be included, and that what is done in the WFSBP, we have like category a recommendation grade 1, 2, 3, 4, and included with a risk-benefit ratio, which takes into account also the different available side effects. So I have to say we are the only one who do this in a rigorous manner. Like the BAP guidelines from the British Association of Psychopharmacology, when they give recommendations, they only talk about different efficacy grading and not about side effects, which seems to be lost. So the guidelines, I told you what they say, and ideally they should not only have categories of evidence, but also recommendations, what should be available in the clinical practice. But still having this sophisticated approach, there is a large number what the guidelines do not say, and at the end of my talk I would like to talk a little bit about this area, what they do not say. And let me give you an example. For bipolar disorder seems so easy. Mania is going up, depression is going down, but usually, quite often, only very mild to moderate patients with the severity, they enter the different trials because they do not fulfill the the exclusion and the inclusion criteria, if they are more severe, which reflects the clinical praxis. The presentation of rapid cycling or mixed episodes is very rarely been taken care of, and the comorbidity, for instance, with anxiety disorders or personality disorders are usually not addressed. However, we know that our bipolar patients have a comorbidity of anxiety disorder at least with 60%, and therefore it would be important to have 2 double-blind, randomized, controlled, placebo-controlled studies for all of these boxes, right? But this will not be available. Unfortunately, all these studies would be too expensive, so we need to extrapolate. But we need to be aware that also the recommendations, they are no cookbooks that you can do one of the other and still leave room to further clinical important issues. This is mentioned one more here, like bipolar 1 patients, just maximum 1/10 of the patients, they are included. Usually they fulfill the registration purposes, and the guidelines usually do not include the established treatment approaches like older medications or like electroconvulsive therapy or like also lithium. For bipolar disorder, you're probably aware, only with the emergence of the atypical antipsychotic, the good old lithium was studied more substantially, which was before only an open treatment approach available. With the new antipsychotics, you find direct comparisons also available. There's also a time lag between the different treatment guidelines are published and the studies are available. Like some of the atypicals, they could be categorized much higher, but since they are not used with the doctors, it doesn't make sense to make them high recommendations. This needs to be taken care of. So let me summarize from a global perspective. It's important that we include cultural beliefs and attitudes towards the different diseases here. For instance, for depression, legal and regulatory authorities need also be taken care of. Also, the healthcare payment system, the support from profession bodies and opinion leaders, the drug availabilities are all different measurements which need to include there. And I would like to warn you once more, the meta-analytic approach is quite problematic. However, drug authorities, sometimes they like the meta-analytic approach very much. And those of you who read, for instance, this Cipriani paper in Lancet thoroughly, the first line medication was escitalopram, but the second line was sertraline. But then the authors, they concluded everybody should use sertraline because sertraline is generic and is cheaper and therefore should be used. But they didn't do a formal study, a cost-efficacy study, so this also is problematic. So there is a level of evidence for the evidence-based medicine judgment of treatment. The highest evidence still has the head-to-head placebo-controlled trial perspective. And please keep in mind, no medication was ever licensed based on a meta-analysis. So it doesn't make sense to take meta-analysis for judgment if this medication is good or bad. Let's take, for instance, lamotrigine, Lamictal. There were 3 inconclusive studies which were not statistically significant, and 2 studies which were a little bit significant. If you put all 5 together, suddenly it's significant. So if you increase the number of the patients from the different studies, then you have a significance. The second level would be like a specialist-based, systematical, critical review of all available studies. For instance, the WFSPP guidelines fulfill this. And the third level would be the meta-analysis. But I once more would like to ask you very carefully to look at the selection criteria, what they have selected. But the more and more complicated the statistical analyses are, the less they are understood. And you need to be a statistician to understand all this. But let's get the message. If they get too complicated, usually
they hide something and try to convey a message. In the last slide, I just would like to thank you very much for your attention and look forward for questions. Thank you very much.